Welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. So let's continue the UPSC question paper 2021. So we'll continue with the questions. So the next question what we have is, which one of the following is the most important hepatological condition to be ruled out while investigating a case of puberty menorrhagia? So when somebody has heavy menstrual bleeding during puberty, you call it as puberty menorrhagia, right? So which one of the following is the most important hematological condition which you have to rule out when you have a patient with puberty menorrhagia? So menorrhagia is actually now replaced by heavy menstrual bleeding. So that is when they have bleeding for more than 80 ml or more than 8 days. So the causes for heavy menstrual bleeding or menorrhagia is, so we have puberty, that is HPO axis immaturity. So most common cause of puberty, heavy menstrual bleeding or your puberty menorrhagia is immature HPO axis. So there will be HPO axis immaturity, which is also abnormal uterine bleeding. Next, very important, it is mainly because of the coagulation disorders. So ITP, von Willebrand and endocrine abnormalities like hypothyroidism or hyperthyroidism. So puberty, heavy menstrual bleeding, you should mainly try to rule out the coagulation defects. Reproductive age group, most common cause for heavy menstrual bleeding is pregnancy related complications. Apart from that, it can be due to fibroids, polyps, adenomyosis, endometriosis and endocrine abnormalities. So apart from that, it can be due to fibroids, polyps, adenomyosis, endometriosis and endocrine abnormalities. Now perimenopausal, most important, you have to always rule out endometrial hyperplasias, cancers, again immature HPO axis, fibroids, polyps, adenomyosis and endometriosis. So all these are the causes for the perimenopausal group of heavy menstrual bleeding. So here, which one of the following is the most important hematological condition to be ruled out? So I told you it is one of the important is coagulation disorders. So you have to rule out coagulation disorders in the puberty menorrhagia when you are investigating for the puberty menorrhagia, right? A couple presented to the OPD with complaint of inability to conceive for last 3 years. Husband was advised semen analysis. What is the WHO criteria for minimum sperm count per ml in normal semen? So very recently, earlier we had WHO 2020 criteria. Very recently we got WHO 2021 criteria. So I'm going to tell you what is the 2021 criteria now. So the 2021 criteria is, so minimum volume of the semen is now cut down to 1.4 ml. Earlier it was 1.5 ml. So sperm count per ejaculate remains the same. It is 39 million per ml. pH is 7.2 to 7.4. So motility of the sperm, earlier it was 40%, now motility of the sperm should be 42%. Progressive motility should be 30%. Earlier this was 32%, now it is 30%. Vitality, minimum sperm should be, which we should be alive, should be 54% now. Earlier it was 58, now it has been changed to 54. Morphology remains the same like previous, so minimum 4% should be normal, right? So sperm count per ml, it is 15 million is the 15 million per ml. So the answer will go for 15 million per ml. Per ejaculate is 39 million, per ml is 15 million. So this 1.5 has been changed to 1.4. pH should be 7.2 or more. Count 15 million or more. So motility, which was earlier 40%, now changed to 42%. Progressive motility, which was 32% earlier, now has been changed to 30%. Vitality, 58% is given, now it has changed to 54%. Right? So leukocyte count should be less than 1 million per ml. Round cell should be less than 5 million per ml. Agglutination should be less than 10%. Okay. So normally aspermia means absence of semen, azoospermia means zero sperm count, asthenospermia means less than 40% motile sperms, oligozoospermia is count less than 15 million per ml, teratospermia is less than 4% normal sperms. So 42%. So this is regarding the other terminologies which you should be knowing regarding the semen analysis. So in this exam, there was 2 questions about semen analysis. So which one of the following is an abnormal parameter in accordance with WHO semen analysis criteria? So volume 2 ml, yes, it should be more than 1.5. Viscosity more than 4. Progress forward motility of sperms more than 50%. So normal morphology should be of the sperm should be more than 14%. So which one of the following is an abnormal parameter in accordance? So here volume is good, more than 2 ml. Progressive motility should be more than 40%. It is more than 50%. So this is also normal. Sperm morphology is more than 14%. It should be more than 4%. So this is also normal. So viscosity of more than 4 is bad. So viscosity ranges between 1 to 4. If you have more than 4, it means it's very sticky. So that's bad. So which one of the following is abnormal parameter? Viscosity more than 4, right? Which of the following are the risk factors for developing of PID in females? Use of oral contraceptive pills, multiple sexual partners, low socioeconomic status and or genetic predisposition. So which of the following are the risk factors for developing PID? So use of OCPs is not a risk factor. It is indeed protective because progesterone causes cervical mucus thickening. Multiple sexual partners, yes. Low socioeconomic status, poor hygiene is also one of the risk factor for PID. Genetic predisposition has nothing to do with the PID. So the answer will be 2 and 3. Do we have the option of 2 and 3? So we don't have the option of 2 and 3. We have 1, 2, 3, 1, 2, 4, 1, 3, 4, 2, 3, 4. Now one thing is very clear that I want a combination where I have 2 and 3. So I rule out. So we have one. Sometimes you do have such things, you know. So between 1, 2, 3 and 2, 3, 4, I think more better is to go with 1, 2, 3. But I don't agree that use of OCPs are acting as a risk factor. Indeed, it decreases the risk of the PID. So, but genetic predisposition, we normally never have genetic predisposition with PID. So, as genetic predisposition to be included, then worst is use of OCP. So, I'm going with option A instead of option 4. But basically, the answer should have been only 2 and 3. Right? A 65-year-old postmenopausal lady presents in the gynecological OPD with abdominal distension and weight loss. On investigation, she was diagnosed to have ovarian tumor. The most common type of ovarian tumor in this woman would be. So 65 years, extremes of age, most common is epithelial ovarian cancers. Germ cell ovarian cancers are usually seen in young women between 15 to 20 years. Sex cord stromal tumors usually range between 20 to 40 years. Epithelial ovarian tumors usually range more than 65 years. Okay. So, which of the following are the, and again, in the epithelial also the most common is serous cystadenoма or serous cystadenocarcinoma, right? Which one of the following are the characteristic features of Meigs syndrome in a female? Right-sided hydrothorax, ascites, genital warts, fibroma. So, Meigs syndrome is right-sided hydrothorax plus ascites plus fibroma. So, that is 1, 2, 4. 1, 2 and 4. Okay. A 25-year-old girl is presented to the gynecological OPD with complaints of abdominal pain, heavy menstrual bleeding, with a mass arising from the hypogastrium corresponding to 16 weeks gravid uterus. Her urine pregnancy test is negative. The most likely diagnosis would be. So, when there is some mass which is arising from the, and which is filling in the hypogastrium, the lower border is not there, right? And it is associated with pain and heavy menstrual bleeding. So, whenever the lower border is not felt, it is more likely to be uterine, right? So PID, the mass uterus will never grow to 16 weeks size. Yeah, it can be ovarian tumor. It can be ovarian tumor, but its abdominal pain and heavy menstrual bleeding are less likely with ovarian tumor. Usually ovarian tumors are asymptomatic. This is very classical of the fibroid. So fibroid can be associated with pain, heavy menstrual bleeding, and it can be associated in the age of 25-year-old, and it can grow to a size of 16 weeks. A 39-year-old nulliparous female has presented to gynecological OPD with complaints of postcoital bleeding for past 6 months. The first investigation to be offered to this female will be, see, whenever a patient presents to you with directly with postcoital bleeding, and that to so many episodes, I am most worried about CA cervix. So when I am worried about CA cervix, instead of doing the screening test like pap smear, I will directly go for a confirmatory test with colposcopy. So colposcopy guided biopsy would be more better answer.